This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. We're so delighted you're with us today. And you know, Thomas, we're making incremental progress against COVID-19. Not there yet, but we're making it incrementally.
Well, and I hear that the numbers in Dallas have plateaued. And, you know, like you say, we'll take any morsel of good news.
Absolutely. You know, it's been spiking. COVID has been spiking in different areas of the country. We've plateaued here. We're not continuing to go down, but we have not gone up. But we got to watch it very carefully because if you remember, back when it was in New York really bad, back last spring and early summer, it was 2 to 3 weeks before we began to spike here. So we got to keep our eyes on this.
So we have more available vaccines. We have more people getting vaccinated. We're going to talk about herd immunity here in this program in just a few minutes, but we are moving in the right direction.
We're definitely moving in the right direction, and I'm going to say something, Thomas. I know people are tired of hearing it, but please continue to wear your mask, physical distance, and wash your hands until we achieve herd immunity. You got to do that, even if you've gotten your vaccination. If you're out among people that aren't vaccinated, you need to wear that mask.
We are not done yet. Now, we're going to talk about another big advancement in this front line of COVID.
You're exactly right. In fact, we're going to talk about the community. You know, a lot of your health happens outside of a doctor's office or outside of a hospital. And so you have to take care of yourself. We're delighted we're going to have Dr. Steve Miff with us. He's the president and CEO of the Parkland Center for Clinical Innovation, obviously affiliated with Parkland. And he's got a very touching story that I hope our listeners will understand why so much of the health and the impact on us happens at the home and within the community.
Quick setup here. Our guest, Dr. Miff, heard a trauma surgeon tell this very touching story about an encounter one night in his emergency room.
He shared that early in his career, he got a child, 15 years old, with a gunshot wound to the chest. And despite all the efforts that they went through, they were not able to save his life. And he was walking towards the waiting room, dreading the need to share this painful, tragic information with the child's mother. She could tell that the news was not going to be good. And he started to tell her that, ma'am, despite all our efforts, unfortunately, your son died from the gunshot wound to his chest. And the child's mom looked up at him and said, Doc, he did not die from a trauma wound, a gunshot wound to the chest. He died from asthma. And finally the doctor said, well, how is that? She said, 2 years ago, I lost my job, and during that transition, we really couldn't afford his asthma medication, and we kind of let it slip. And his asthma got worse. We didn't get to see a doctor, but it got so bad that he was not able to participate in the after-school football team he really enjoyed. And because of that, he filled his time by just hanging out with kids in the neighborhood, and one thing led to another, and got involved with the wrong crowd. And here we are today in the hospital. So he did not die from the gunshot wound. He died from asthma because we couldn't have the resources to really help him control it. So, Steve, this really got to my heart and put in perspective that oftentimes there are these things that we can maybe understand and control much earlier and prevent some of the more tragic or chronic things that individuals suffer down the road.
You know, we all know about those social drivers of health, people's financial security, their food security, their overall economic security, transportation. All of these factors come into play in your health. And you know what? All of that takes place outside of the medical community. It's in your community, it's in your home, and it's in your hands. That's what's really driving a lot of the chronic illness in this country.
Up until now, most healthcare innovation has focused on what I'll call sick care. But we all know that one of the paradigm shifting lessons we've learned as an industry is that non-medical factors, things such as environment, lifestyles, influence about 40% of health outcomes and costs, and that more than 80% of health is actually determined by what happens outside of the doctor's office. Or we know, put another way, that health doesn't begin in our hospitals or doctor's office, but rather where we live, work, learn, play, or pray. So our goal and intent is to do something about this and are actively participating in how healthcare transforms itself.
You know, Thomas, Steve Miff's done a lot of work with data, modeling, and he can even pinpoint through something called the Personal Proximity Index near your residence where you can be exposed the most to COVID-19.
The best way I can explain it is that this gives an individual context of what's happening relative to active COVID cases around them and puts it into one number. As you know, at the beginning of the pandemic, one of the questions that everybody was asking was, did you travel to China or were you in Italy? And if you did, that meant that you were likely at higher risk because you were close to or in proximity with other people that were infected. So you needed to pay a little bit closer attention. And since then, I think we all anecdotally have known, from neighbors, etc., who in our neighborhood might have been infected just through word of mouth. And so, did you hear that Mrs. Brown's sons both had COVID, etc.? And while that's useful, what this proximity personal index does is takes all that information of what's happening around you and puts it into one score to give you the context of, are there a lot of people or maybe not who are currently infected? And it gives you that information of what action you can take yourself or your family to continue to protect yourself.
That's pretty interesting. And that's a clumsy analogy. It's almost like you get your credit score. This is really telling you in your neighborhood just how much personal risk do you have based on this number to COVID.
That's exactly right, Steve. And it becomes even more relevant if you live around a lot of people. Particularly if you live in an apartment complex where you might be sharing laundry facilities, you might be sharing elevators, and knowing what that risk is gives you that information, and then you can use it to protect yourself and your family.
That's a very good point, because you mentioned early on when we had the pandemic, did you go to China or did you go to Italy? And in Italy, many families live together. So this personal proximity index in Italy would have been extremely valuable.
It would have. We only wish we can wind back the clock and make some of the things that we know now or have available now back then, certainly.
If you want a ray of hope from COVID, stay with us. You're going to get it in the next segment. A bold comment from Steve Miff coming up next on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
And welcome back to the human side of healthcare. Steve, question. I've been wondering how this works. So we're vaccinating more people. It's going to be wide open by the end of the month. And we have these variants out there. Can you help put all that together?
Absolutely. And the reason we want to get ahead of the curve and get as many people vaccinated, those variants are much more contagious than the original COVID-19. And guess what? Those variants are here. They're in North Texas. So we've got to get as many people vaccinated, because if you should get the variant and the vaccination, at least it won't be as severe. But we've got to get shots in arms.
We're talking with Steve Miff. He's with the Parkland Center for Clinical Innovation, which is a joint venture with Parkland Hospital and his nonprofit organization, and they are taking healthcare out into the community. So we're going to address the question of why we need to vaccinate so many people so that we achieve herd immunity.
You know, Steve, PCCI has done some work on herd immunity. To our listeners out there, some may not know what herd immunity is. Can you explain what that is?
Absolutely, Steve. And the way I think about it is that the more people who have immunity, the harder it is for the virus to spread. So, a good analogy might be the fire analogy. So if you have some of the brush fire that has already burned, which in this case is people who have been infected, or some of the brush that you proactively cleared away and cut down, that maybe correlate that to people that have been vaccinated. If a fire happens, or in this case a COVID infection, it does not spread beyond that area or household or neighborhood, since there is nothing else to burn or nobody else to get infected. So herd immunity is really reaching about 80% of the population who have a level of immunity, either by previously being infected or by having been vaccinated. So when somebody else in that area gets infected or gets COVID, there are not enough, or there's a small number of people around them who can get infected. And if they do, then the virus remains contained in that small area.
Great. So looking in your crystal ball, let's pick North Texas. When are we going to reach herd immunity?
We are still forecasting, Steve, that we're on track to reach herd immunity by middle or late June. So we put that prediction out there about a month ago, and with the data through middle of March, we're still on a pace to hit that. We have, as the middle of March, vaccinated over 17% of the population, about 36% of the population who've been previously infected with COVID, those that have been confirmed as well as those have been presumed. So we are on a path to still reach that herd immunity by the middle or late June.
You know, that's a fascinating prediction, and I love to hear it. But now I'm going to play devil's advocate, if you'll allow me for a minute. So we know we've got some people that just aren't going to get vaccinated. There are other people that are going to get vaccinated, but they have a wait and see attitude. I'm going to wait about 6 to 12 months. I want to see what some of the side effects are. And then you have a group of minorities who in the past tragically had some medical experiments, et cetera, that make them skeptical, which we certainly appreciate. And then, of course, you've got women of childbearing age. Some are very reluctant to get vaccinated. You throw into that, Steve, I think, I could be wrong, about 20 to 25% of our population are children or adolescents, and they have not been vaccinated. How in the world are you going to achieve 70% by June?
Yeah, and Steve, we get there both by infections and by vaccinations. However, we do not want to get there through infections. The best and safest way to get there is through vaccinations. And roughly speaking, we need to vaccinate over 1 million people in Dallas County to be able to reach that number of herd immunity. Now, this takes into account all those different factors that you've articulated, Steve, because we know that some children in particular are not yet going to be eligible or have a vaccine that's approved for them. We know that different ethnic racial groups might be more skeptical than others. We know that not everybody is going to jump at the chance to get vaccinated. So we've taken those into account. My recommendation is that we want everybody to try to understand what does it mean to be vaccinated, both the risks as well as the rewards. And that needs to come from the sources that they trust the most. So we need to continue to provide very transparent information the latest information that we have, because with every day we learn more and more. And I think with every day we learn that these vaccines are safe and these vaccines are effective. So we need to continue to empower people with the right information through the sources that they trust the most, to be able to first make the decisions for themselves and for their family that this is something that will benefit them and will benefit the community. But equally, Steve, we need to continue to make it easy for people not only to get the information, but also to register to receive a vaccine and then be able to make it to the places that are administering them. That is something that's equally important to ensure that everybody has the opportunity to receive the vaccines when they're ready.
That's great information and totally agree with you. I do want to go back to something you said in your answer. And you're so right. You have to look at the people that have been infected, and then you have to look at the people that have been vaccinated. But I'm sure you're not saying to our listeners, if you tested positive and have been infected with COVID-19, you don't need to bother to get a vaccination, correct?
No, absolutely. Everybody should get vaccinated. And even those that have been infected, it is safe and recommended for them to also get a vaccine.
You mentioned achieving herd immunity in the Dallas area or Dallas County. What happens when you achieve it here, but maybe you haven't in Tarrant County or Rockwall County or even San Angelo or Houston? What happens then?
Whether it's in our own neighborhood, our whole county, our whole North Texas, or the state, Steve, we need to get there together. And some areas certainly will get there a bit faster than others, but the only way to reach herd immunity is by everybody being able to make progress and get there at a fairly rapid pace. Because the other thing that I will say, Steve, is that this is a sprint. This is something that we need to be able to crush COVID and get there ahead of giving the virus more opportunities to create new mutations and new variants. We need to get there fast, I think both personally, emotionally, from a business perspective, but also from a disease perspective. And the only way to get there is to be able to get there as a whole community, as a whole state, as a whole country.
Excellent advice, and I couldn't agree with you more. And you touched on the next question I was going to ask, but I'm still going to ask it, so you may want to elaborate. As you've done this work and as you've done this predictive modeling, new variants have arisen. Did you go back and tweak your projections, incorporate the variants, or how have they impacted your work?
That's a continuously moving target, so to speak, but we did take heavily into account the variants that were existing when we made the predictions and we made the forecasts. All indications are today that those active variants, some are much more transmissible, meaning that it's easier for people to get infected. They have not significantly impacted the immunity that people are reaching, whether they've been exposed and infected or through the vaccinations. So for now, we are still able to have that immunity by being vaccinated, et cetera. So that's an important factor. Because, again, while we're currently able to maintain those levels of immunity, we don't want to give the virus a chance to mutate again or to create new variants in a way that the vaccinations becomes less effective. So that's why it's a race game.
Thomas, I think Steve Miff said it best. It is a race game. We've got to get those vaccinations. I'm going to pivot quickly, though, and Thomas, I'm going to make a confession. When I was a teenager, I laid on the beach too much, got too much sun. And as a result, as I get older now, I'm paying some of the price. We're going to talk to Dr. Murray Hurley, who's a dermatologist, in our next two segments, and she's going to tell us the do's and don'ts related to taking care of your skin.
And if you've missed some of our shows, like the one we had last week about pregnancy and COVID and the COVID vaccination, you can catch them all on our podcast, The Human Side of Healthcare, on all the major podcast players. Our Skin in the Sun next on The Human Side of Healthcare.
The DFW Hospital Council, along with our over 90 member hospitals in North Texas, are proud to bring you the human side of healthcare with Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome to the Human Side of Healthcare. We're delighted you're with us today. And we are also delighted that we've got Dr. Mary Hurley with us. She's a dermatologist who serves on the medical staff at Texas Health Presbyterian Hospital located in Dallas. Dr. Hurley, welcome to the show.
Thank you. Thank you for having me today.
You know, we're going to kind of divide this Q&A with you into two categories. One, we're going to ask you about some of the things related to dermatology during COVID-19, and then we're going to also ask you some questions about dermatology in general. But, you know, I hadn't really thought about this, but we tell people wear a mask, physical distance, and wash your hands. Are you seeing many people, because of skin issues caused by too much hand washing or stress during the pandemic?
Absolutely. Yes. So as you know, everybody's been washing their hands a lot more during COVID. So we have been seeing a lot of hand dermatitis, really dry skin associated with the hand washing. And then also on the face, because of the mask, people have been getting acne and breakouts. We call it maskne. So those have probably been the top two COVID-related dermatologic issues that we have seen. And you mentioned stress. So stress makes any kind of inflammation on the skin worse. So it's been a time of high stress for sure.
You know, to our listeners out there, do you have some tips to help them relieve dry skin?
Oh, yes. I've got lots of tips. So I like to just kind of keep it simple, but avoiding hot showers or baths. Everybody likes the hot water, but ideally if you could use cooler or tepid water. You want to limit the time in the bath or shower, ideally about 5 to 10 minutes. And then when you get out, you want to moisturize within about 3 minutes. That helps to lock in the moisture. So you want to pat yourself dry. An ointment is better than a cream, is better than a lotion. So meaning an ointment such as Vaseline is going to be more emollient and moisturizing than a cream, which has more water, and then lotion, which has even more water. Also using a gentle cleanser such as unscented Dove, or a soapless cleanser such as Cetaphil or CeraVe. Those are great gentle cleansers. Avoiding harsh soaps and detergents. Again, everybody's using the antibacterial hand washers, hand soaps and detergents. So avoiding those. Using fragrance-free skincare products. That's avoiding things like the ones that smell good. So the ones that have too many colors and too many flavors, and those are the ones that can be potentially very irritating. Also wearing gloves for people who work outside or work with water or work with chemicals. Gloves are a great way to protect the hands. Another tip is to wear cotton gloves at night. If you've got really dry hands with cracks and fissures, putting some Vaseline or Aquaphor on, wearing some cotton gloves at night, and doing that trick, even just for a couple nights, wearing those cotton gloves can really be a great way to relieve dry skin quickly.
You know, if I were at a drugstore or even at a grocery store in the pharmacy section, and I was looking at the moisturizers, are there any specific ingredients that I should look for?
Yes. And when you're standing there in the drugstore and you look at all those products and different ingredients, it can be confusing. It's hard to sort through it all. So again, I like to try and keep it simple, break it down for my patients. There's 4 categories of moisturizers: humectants, emollients, occlusives, and what are called barrier repair. So we'll go through each category. So humectants draw water into the skin. They hydrate the skin. 2 top ingredients to look for would be glycerin and hyaluronic acid. And again, those are going to draw water into the skin. Some brands to look for would be Cetaphil cream or CeraVe cream and Neutrogena Hydro Boost. Emollients is the next one, and so those help to lock in the moisture. So they smooth, soothe, and soften the skin. And ingredients there would be dimethicone. It's got a really nice glide. It's what makes the moisturizers slick. Mineral oil is another one, shea butter, and cocoa butter. And my top one from that category is called Lipicar Balm. And the next category is occlusives. And so those are real things that provide a real thick protective barrier. Ingredients to look for would be lanolin, which is found in Aquaphor, and petrolatum, which is found in Vaseline. And I love Vaseline. I recommend it all the time. It's great. It's not irritating. It's very moisturizing. You can put it on your lips. You can put it on your body. It's great for really dry skin. Great for hand eczema and, again, dry skin on the hands. And then the last one is a relatively new player in the arena of moisturizers, and it's under the category of what's called barrier repair. So you want to look for ingredients that contain ceramides, which are lipids, and they help to repair the top layer of the skin that gets stripped away with really dry skin. So ingredients here would be jojoba oil, sunflower oil, grapeseed, and poppy seed oil. And brand defined over the counter is CeraVe cream. And again, that helps to repair that top layer of skin, and it's a great moisturizer.
How often should a patient see a dermatologist?
At least once a year. Everybody needs a once a year head to toe full body skin exam, which is a skin cancer screening and a mole check. I think most people know that you need to go see your internal medicine doctor once a year and your dentist maybe twice a year, but many are not aware that you need to see your dermatologist once a year to get your full body skin exam.
Are there any specific warning signs that would make you go in much earlier than your regularly scheduled appointment?
Absolutely. So a couple simple things, which would be anything new, so any new spots, anything that's changing, so changing in size, shape, or color, or anything that's not healing. So sometimes skin cancer can start as a little spot that's bleeding, crusted, not healing. Anything like that, you should come in right away.
You know, as we hear a lot about the upcoming summer, the spring, summer, people want to really get out. They're fatigued from COVID. As they go to the beach, as they lay out in the sun, what types of sunscreen should they use, and what are your recommendations?
Lots of sunscreen. So we don't expect anybody to stay inside and not go enjoy the nice weather. But as long as you wear sunscreen, and wearing enough of it are the key factors. So you want to apply about a shot glass full to the body, and then reapplying frequently enough. So you want to reapply every 2 to 3 hours if you're going to be out all day. Also wearing a hat, again, if you're going to be out all day, and protecting the lips is important. There are two types of sunscreens, and they're under the category of chemical sunscreens, which have chemicals that you absorb that help to protect you from the sun, and then physical block sunscreens. So these provide a true physical barrier or block from the sun, and these are things like titanium and zinc oxide. And they're a lot better than in my day, and so they are mineralized now, so they're not quite so white and visible.
So to your patients, do you give a recommendation on the strength of the sunscreen or the block they need?
Yes. So for everybody should wear a daily moisturizer with sunscreen. Even just going in and out of the house, going to lunch, walking around town, going to work, going to school, you get sun. And so the studies show that day-to-day incidental sun exposure over the course of a year, it adds up to about a week's vacation at the beach. So for daily wear, I recommend a 30. Again, that's just for going in and out of the car, going to work. If you're going to be out all day, if you're going to do outdoor sports or activity or going to the beach, then I would recommend at least a 50, so 50 or greater. And you've probably seen them at the drugstore, but they have 50, 60 on up to 100. So there are newer studies that show that you do get a little incremental increased exposure with a higher number. It's not much, but you do get a little additional protection. So I think the higher the better, but at least a 50 for outdoor sports or activity.
So what about our listeners who have haven't been out much in the sun, and they go, ooh, I need a suntan. So before I go to the beach, I'm going to run down to the tanning salon. What do you think of that?
Ooh, I think that's a bad word. So there's no such thing as a healthy tan. Basically, think of it like cooking your skin. You might as well just get in the microwave or get in the oven. And the tan boosts actually can potentially be more harmful than the sun. So the tanning boosts contain penetrate the majority of UVA waves. So UVA is a longer wavelength and it penetrates deeper into the skin. So these are more of the aging rays and also links with melanoma. So melanoma is associated with that longer wavelength, the UVA wavelength, whereas the sun has the majority of UVB rays. And so UVB rays contribute to non-melanoma skin cancer. So you do want to protect yourself from the sun, and ideally you do want to avoid the tanning beds.
You know, I'm an old guy. I remember when people would say, well, I've got to go ahead and get a good sunburn and let it peel so that I'll be ready for the rest of the summer. For people that really burn their skin to the point they peel, can you take us through what they're doing to their skin and to their body?
Yes. So sun damage is cumulative. Think of it like a car's odometer. It records all the damage and you can't turn it back. So each time you get a sunburn, and particularly before the age of 18, increases the risk for both melanoma and non-melanoma skin cancer. They've done studies, and you can look at the pictures of the cells and what happens to the cells. They're called sunburn cells, and they get all dried up. There's damage to the DNA, and once that damage happens, it's there. It's in the DNA, and like I said, you can't turn it back. So again, it's a cumulative effect. You want to try and avoid any damage, and the majority of sun damage that we get in life is prior to the age of 18. So about 80% of sun damage occurs before the age of 18.
So your actions before age 18 can really affect you with skin cancer later in life.
Yes, absolutely. And I think most people before that age are not really thinking about that. And I would say myself included. I grew up on the beach in Florida, and we did all kinds of terrible things. So now I'm the one in the shade with my sunscreen on and spraying down my kids and trying to avoid as much sun as I can.
This is Dr. Mary Hurley, a dermatologist on the medical staff at Texas Health Presbyterian Hospital, Dallas. You know, there's been a lot of conversation on the street about the COVID-19 vaccinations and fillers. Would you like to hear what a dermatologist has to say about that? Well, Dr. Hurley is going to tackle that first when we come back, next on the human side of healthcare. Stay with us.
We're continuing our conversation on how you can empower yourself to have the best health possible in today's ever-changing healthcare environment. This is the human side of healthcare with DFW Hospital Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome back to the human side of healthcare. We're going to continue our discussion with Dr. Mary Hurley, who is at Texas Health Presbyterian Hospital, Dallas. And, you know, are you seeing any correlation whatsoever between vaccines and fillers in your treatment of patients?
That is the hot topic and question of the day. And fortunately, I have not. But it is very, very rare, and I would like to emphasize that. There has been a lot of attention in the media about it because of the timeliness of it, but there is no greater increased risk of having a reaction from the vaccine associated with filler than there is any other vaccine, such as the flu vaccine or, again, any other vaccine, or even with any infection. So with any bacterial infection or a viral infection, all of these things can create an immune response in the body. And so that immune response can trigger an inflammatory reaction at the site of filler. So redness, swelling, localized. So localized redness or swelling in the area of previous filler. However, again, it's very, very rare. In the reports, there were only 3 patients reported from having the COVID vaccine. So again, extremely rare. But again, it's just the timeliness of it. There's been a lot of hype about it in the media.
You know, you mentioned, of course, melanoma, and we know how serious that is. And we know that is something you can't neglect and you shouldn't neglect. And you need to go to your dermatologist and have it taken care of. But for the other non-melanoma skin cancers, you shouldn't neglect them either, correct? Like you may have to get Mohs surgery for a non-melanoma.
Correct. While they can be slower growing, they can still be dangerous and harmful and can grow. Basal cell carcinoma is the most common form of all cancer combined, meaning just about everybody's going to get a basal cell perhaps. So it's very common, and they look so indolent. When they first come up, they look sometimes like a little pink spot. And so that's why it is important to see your dermatologist to get the full skin exam. I recommend self-skin exams at home as well to keep an eye on your spots, get to know your moles, so that way you can notice changes. So notice if there's something new changing or not healing. You want to watch your spots.
I talked to a good friend of mine, this was 20 years ago, a dermatologist, and he told me people sometimes forget they need to check their hairline, they need to check their scalp, because you could have moles anywhere.
Absolutely. Yes, you can have moles or skin cancer that have never seen the sun in all kinds of private spots and areas and in between the toes and behind the ears. So that's why we do a very careful screening exam. We check your scalp, we work our way down, check all the nooks and crannies, and check between your toes. And again, that's part of that comprehensive full body skin exam that we talked about.
And when a patient comes in and gets that full body head to toe exam you referred to, I can only imagine if someone has quite a few moles, to make sure that you're tracking it, you probably have to take pictures sometimes or even measure the moles and chart it so that when they return, you know if they're growing. Or is that one of the techniques you use?
Yes, absolutely. So we do measure, we take photographs. Sometimes I'll take the patient's camera and take a little picture so they have a selfie so they can watch it at home. But if there's ever a doubt, we do a biopsy. So we take a little piece of the tissue or remove the mole or the spot. We send it off to the lab and have it looked at under the microscope.
Could you walk us through common problems almost by decade? So let's start with under 50. What are common dermatologic problems that people have under 50? Well,
in the earlier years, one of the common things is adult acne. So it's not just for teenagers. We see it a lot in 20s, 30s on up. It's similar to garden variety acne, but that's a common problem. As people get older, around the age of 40, sometimes that can evolve and can turn into something called rosacea, commonly known as acne rosacea. But it does have an acne component, and it's kind of a hyperreactivity of the skin where the skin becomes sensitive and people can get redness, can flush and blush, and again, the acne component as well. We have discussed dry skin. So as we age, our skin becomes a little drier over time, and it's important to moisturize, particularly for women as we lose estrogen over time, even beyond the age of 50. Again, we lose some of the moisture in our skin. It becomes dry, cracked, and wrinkled. Other skin problems under age 50, I mean, you name it. We take care of the whole gamut of skin problems, such as warts, moles, skin cancer. And skin cancer is not just for older patients. We see it all ages. I just saw somebody the other day in her 20s with a basal cell. So again, all the more reason that everybody needs that once-a-year skin check.
Okay, and then what do we look for in our 60s?
In 60s, starting to pay more attention to things on the face. So people are oftentimes wanting to prevent aging, particularly photoaging. So again, wearing your daily sunscreen, looking for precancers. Precancers start as typically just a little red, rough, dry, scaly spot. So for people who've been in the sun for years and years, sometimes these little spots start to show up, and people oftentimes want to just pick or peel them off. They're not really sure what they are, but that can be a sign of, again, a precancer, which can be easily treated. You also want to just look at all of your moles, again, for any changes. Dysplastic moles, which are considered atypical moles that have unusual features under the microscope. And moles can change over time, and they can evolve from a dysplastic mole, again, an atypical mole, into melanoma. So looking for changes like that. Sometimes people have inflammatory skin conditions such as eczema, psoriasis, all kinds of inflammatory skin conditions, and they can change over time. So it's not just before or after the age of 60. But those are some important things to look for. Thinning of the hair is another thing that occurs. It's an age-related phenomenon. 50% of all men over the age of 50 get a genetic form of hair loss called androgenetic alopecia. So those are just a few things. There are many. We could be here all day talking about all the dermatology things that there are to look for. And I think I can't go to a cocktail party or out without people asking questions about this, that, or the other. So
probably true. Now, our bodies change a lot in the 70s. What new kinds of things in the 70s become more prominent issues?
Well, one thing that we didn't talk about even prior to age 70 is wrinkles, an age-related phenomenon. So around 40 to 50, people start to notice lines in the frown area, 11s, become crow's feet around the eyes. And so those are the years that people start to think about, okay, well, what can Botox do for me, or what can I do about those lines? So Botox and filler to help soften the signs of aging. My philosophy and approach is everything should look very natural and gradual and not look like you've had anything done. So around that time frame, 40s, 50s, 60s on up, people are interested in skin rejuvenation techniques. Another very common thing that we see is toenail fungus. And it can be difficult to treat and stubborn and chronic, but there are new things that we can do now. Even topical therapy has come a long way. So no need to suffer with gnarly nails. We can help with that.
Awesome. And then if we make it so lucky and we're in our 80s and beyond, what are some of the more elderly issues that are faced?
Predominantly skin cancer. So we have many patients that, unfortunately, they're kind of like little factories, and they will manufacture skin cancers time and time again. So for those patients, we do recommend coming in more often. So oftentimes every 6 months or quarterly. And then just benign growth. So some people call them barnacles, but they're these crusty brown spots. I affectionately call them wisdom spots. 1 year older, 1 year wiser, but people tend to manufacture those, and they can be treated. They can be frozen or burned off.
When a rash just suddenly pops up, what causes that?
So a rash is a dermatitis or inflammation of the skin. They're usually red, usually itchy. And so it can be triggered by a whole plethora of triggers, but it usually, again, it means inflammation of the skin. And oftentimes we'll need either a topical steroid to calm the inflammation. There are over-the-counter calming creams. We talked about ingredients, things to look for. So one would be colloidal oatmeal. It's very calming and soothing for the skin. But if it persists, you might need to see your dermatologist.
Thank you, Dr. Hurley. Excellent information, excellent tips. And to our listeners, we really appreciate you joining us today. We know this is a special day, and we hope you enjoy it however you're celebrating.